So now this presentation is going to focus on hydrocephalus and increased intracranial pressure. Granted, ICP or increased intracranial pressure can occur with any type of head trauma, but I'm going to discuss it here as it is often a secondary symptom you're going to see with patients with hydrocephalus. Hydrocephalus is the disturbance in dynamics of cerebral circulation and cerebral spinal fluid. Mechanisms of hydrocephalus include obstruction of the CSF or cerebral spinal fluid pathways is the most common. You may have impaired venous absorption of the CSF related to inflammation of the arachnoid villi, and then maybe over secretion of cerebral spinal fluid. So that's the least common, but no patient actually has a complete obstruction because that is incompatible with life. So an increase in the cerebral spinal fluid causes accumulation in the ventricles. This accumulation causes the ventricles to become dilated, and then they compress brain tissue. So you're going to see the head enlarge. In this image, you have a skull with no hydrocephalus. And then on the right, you're going to see that this is the patient with hydrocephalus. Okay. And you see the enlarged ventricles. You see the flattened gyri and the narrow sulci, okay, as a result of the enlarged ventricles. And like I said, another characteristic is an enlarged head size. So this slide is just a review of the cerebral spinal fluid circulation. You're not going to need to know this, but this can give you a general idea of how cerebral spinal fluid circulates. So a disturbance in the circulation can lead to hydrocephalus. So the cause, like many things, the cause of hydrocephalus varies, but it either results in impaired absorption of cerebral spinal fluid within the subarachnoid space or malfunction of the arachnoid villi. So you're going to have, this is seen in non-obstructive or communicating hydrocephalus, or you're going to have obstruction to the flow of cerebral spinal fluid through the ventricular system. And that's with obstructive or non-communicating hydrocephalus. Hydrocephalus may be caused by CNS malformations, so neural tube defects, infections, trauma, exposure to teratogens or medications or substances that the mother was taking while pregnant, and it can be part of a syndrome. And then it may be acquired if the patient had meningitis, a brain tumor, or a hemorrhage. Clinical manifestations. So 3 factors influence clinical symptoms: the acuity of onset, the timing of onset, structural malformations. And just remember, in infants, head enlargement is a predominant sign that hydrocephalus is occurring. So clinical manifestations will vary depending on if hydrocephalus is occurring in infants versus a child. And these clinical manifestations result because of increased ICP. So manifestations of hydrocephalus in infants will result, like I said, because of the increased ICP and the dilation of the ventricles. So you may see spasms of the muscles causing backward arching of the head, neck, and spine, as in patients with severe tetanus, some kinds of meningitis. So you'll see posturing. They will be irritable, so cries when picked up or rocked, but quiet when they're lying still. If the hydrocephalus progresses, you may see difficulty sucking, feeding, have a high-pitched cry. And just to note, the brain is well protected, but vulnerable to pressure that may accumulate within the cranium. So as pressure increases, the signs and symptoms become more pronounced, and level of consciousness deteriorates. So the early signs and symptoms may be subtle. You can see the rapid increase in head circumference, maybe some split sutures. Anterior fontanelle, so something really specific to infants. If their anterior fontanelle is still open, you'll notice that'll be bulging, tense, and it will not be pulsating. Scalp veins may be prominent. You can see some frontal bossing, setting sun sign, which I'll show a picture of in the next slide, and the aposopnos, so that posturing activity. You can see, you may see McEwen's sign, and that's when if you tap on the head, you can hear resonance because of that increased CSF fluid. And again, you would in infants see evidence of poor feeding and vomiting. So this is the setting sun sign. So you can see, you have your pupil, then you have your sclera, and that's visible above, okay? So it looks like the pupils are suns that are setting. So that's where it gets its name. So sclera above the iris is visible, and that's called that sun setting sign. And then this is, I mentioned the opisthotonus, or the posturing or arching of the back. So it's a spasm of the muscles causing backward arching of the head, neck, and spine. Okay, so a little bit different than your cerebral posturing movements that you would see. So this is that severe arching. And then I mentioned frontal bossing. So that frontal area of the head extending outward as well is a sign of hydrocephalus. And now clinical manifestations for older children, again, what you will see, the signs and symptoms are due to increased intracranial pressure and focal lesion. So you often see headache in the morning, which will improve with emesis and being upright. You can see papilledema, strabismus, ataxia, irritability, lethargy, and they may be confused. They can have forceful vomiting, seizures, diminished physical activity, and the inability to follow simple commands. So assessment for ICP. So monitoring and looking for level of consciousness. So what is their level of consciousness? Is there a change? What is their pupillary reaction? What are their vital signs doing? Your frequency of assessment really will depend on the condition. So it can range, again, it will be dependent on what's going on. But you may be seeing that we're going to be monitoring more frequently because we're concerned that there's a change and they're having increased ICP because of the hydrocephalus. And so you might be doing vitals or assessments every 15 minutes to maybe every 2 hours. And then we want to monitor for those late signs of increased intracranial pressure. So the late signs are bradycardia, decreased motor response to command, decreased sensory response to painful stimuli, having those alterations in the pupil size, and extension or flexion posturing, and having decreased consciousness or even going into a coma. I keep mentioning ICP or increased intracranial pressure. And so clearly anytime some of the patients are displaying some of these signs and symptoms or clinical manifestations, we're going to monitor it for it. And indications to do cranial pressure monitoring are with, if we're having suspected hydrocephalus, if they've had traumatic brain injury, they have an abnormal CT scan, they have a deteriorating neurologic condition. And so really, and also subjective judgment based on the patient's change in status. Is that a concern? Should that be a red flag? Is that something that should be on our mind? So nursing management, what is the nursing management for ICP? Patient positioning, we need to make sure that we're avoiding neck vein compression. We want to allow them to, since they most likely will be in the bed for a while, provide alternating pressure mattress. And we really want to make sure that we're elevating the head of the bed to 30 degrees. We want to avoid activities that may increase ICP and eliminate or minimize environmental noise. So we need to pay attention to suctioning. So often suctioning is a routine nursing procedure. In patients with severe head injuries, it can actually cause or increase intracranial pressure, ICP, and may put the patient at risk for further cerebral damage. So it's really important, if they do need to be suctioned, we just need to be cognizant that it can increase ICP. So like when we're talking about avoiding activities that can increase it, suctioning would be one of those if we can get around it. So in order to diagnose, so with newborns, it's diagnosed by the increases in the head circumference and ultrasonography or ultrasound. In older infants and children, you could do CTs or an MRI. And with patients, you may see a spinal tap done if an infection is suspected as well. And when we're talking about head circumference changes, we know that a newborn or infant has changes in their head circumference. We want to see their head getting bigger. But we're talking about changes in 1 or more percentile kind of lines within a 2 to 4 week period and associated with neurologic signs. Really an increase that we're really not expecting or is above what we're expecting. And that's going to maybe clue us in that this head is, bigger than we would, expect it to be at this time period. So treatment of hydrocephalus involves treating the underlying cause for it. So for non-communicating hydrocephalus, we're going to divert the cerebral spinal fluid flow with a shunt. And for communicating hydrocephalus, do a resection or evacuation of the mass or lesion. Okay, so the treatment of hydrocephalus is directed toward relief of ventricular pressure. So when I'm talking about diverting that flow, often you'll see a ventricular atrial or ventriculoperitoneal shunt is used with that obstructive hydrocephalus. A small opening is made in the floor of the third ventricle, allowing CSF to flow freely through that previously blocked ventricle. So I'm going to go over those different types of shunts on the next slide. So I mentioned the different types of the shunts. So you have your VP, or your ventriculoperitoneal shunt, and then your ventriculoatrial shunt. So the VP shunt, this is when the cerebral spinal fluid flow is directed from the lateral ventricle into the peritoneal space. And this is the most frequently used shunt that you'll see in children. And then the ventriculoatrial shunt, or the VA shunt, the CS flow is directed from the lateral ventricle into the right atrium. And if they ended up having to do a third ventriculostomy, this is perforation of the third ventricle to the subarachnoid space. So here you are going to see an image of a VP shunt. So there is a catheter that's in the ventricle. There is a reservoir and a valve that's controlling and monitoring the flow, the pressure, and then it goes all the way down into then that peritoneal space to then be reabsorbed by the body. Okay, so that's where the CSF is then draining to. And this little reservoir here, something can collect in there. And if we were ever worried about a infection of the cerebral spinal fluid, instead of having to do a spinal tap, they can actually do a tap of the shunt to see and evaluate if it's infected. So pre-op care, we want to make sure we know the child's baseline neurologic status, because again, we need to know the baseline to then understand if there has been a change or if there is an improvement of their status or a worsening of their status. I'm going to do frequent neurological assessments, measure that head circumference daily. If they're infants and they have their anterior fontanelle, monitoring that for any bulging, assessing for split sutures in infants. And then we need to provide patient and family education, what to expect after surgery, and then really provide emotional support for them, okay? And talking to caregivers, explaining to them what hydrocephalus is, if we know the cause, informing them of what the cause is, and helping them understand that hydrocephalus does not always cause problems with cognition, because if it is recognized earlier and treated earlier, you're going to see fewer problems occurring. And know that, again, informing them of how it's actually going to be treated. They know it in explaining the shunt that they are going to get. So now your post-op care, you're going to do vital signs. Again, we're going to do our vital signs. We're going to do our assessments. We're going to look for signs and symptoms of increased ICP. So poor feeding, fever, decreased responsiveness, seizures. We're going to look for posturing, looking at their level of consciousness. And post a VP shunt, are they going to have abdominal distension? Or check for abdominal distension, check their incisions, looking for signs and symptoms of infection. If a person has a shunt, we always want to make sure that you're able to feel it on the side of their head once it's healed, because they can migrate. So it's important when you are assessing and then you're passing along or reporting on these patients that inform the next nurse. This patient has a left VP shunt, it's palpable, knowing that you're able to palpate that on their head. The shunt did not migrate. They're going to be on IV antibiotics afterwards, looking for those signs of infection and then those signs of malfunction. Did they become obstructed again? So they'll show those signs and symptoms of increased intracranial pressure. You can see nausea, vomiting, irritability, bulging of the fontanelles, worsening of their neurostatus. They may have headaches, vomiting, lethargy, irritability, swelling or redness along that shunt tract, decreased school performance, periods of confusion, and then seizures. So again, those would be your signs of a shunt malfunction, because these tubes can kink, they can break, they can migrate, they can obstruct, and they can become infected. So while, yes, they are helping treat the hydrocephalus or that increased CSF fluid, complications can occur. And if we are, like I said, ever concerned for an infection, they can tap them. If the shunt itself does become infected, then while this is an internalized device, if it is infected, they actually have to get the shunt externalized. And so they'll end up having an external ventricular device, treat the infection, get treated with IV antibiotics, and then have that shunt replaced. So discharge teaching, monitoring for complications, all those things that I talked about earlier are about those, looking for those signs of increased ICP, signs of shunt malfunctioning, signs and symptoms of infection, making sure that we're protecting them from head injuries, evaluating their developmental progress. Because like I said, if hydrocephalus is treated, it doesn't always mean that there is going to be delays that do occur, but they still can. So again, really monitoring their developmental progress. Again, helping support that growth and development, okay? So really helping them achieve all of their abilities that they're able to, really to help promote their best growth and development. And I have an image here of a patient with myelomeningocele. This is a neural tube defect, but these patients often have hydrocephalus as well. Okay, so this myelomeningocele is a neural tube defect that occurs early in gestation. So this is the hernial protrusion of a sac-like cyst containing meninges, spinal fluid, and a portion of the spinal cord with its nerves. The defect is surgically closed soon after birth, but effects of having the myelomeningocele really will depend on the level of nerve involvement. So, like I mentioned, the majority of infants also have hydrocephalus, and clinically, you may also hear the patients or the term bifida used to refer to patients that have had myelomeningocele. So neural tube defects are the largest group of congenital anomalies. Normally, what you traditionally see is the spinal cord and cauda are encased in a protective sheath of bone and meninges. This doesn't occur, and you have this failure of the neural tube closure. So you will see varying degrees of defects occurring depending on where it didn't actually close. This does typically occur with 3 to 4 weeks after conception. Why this happens? It can be multifactorial. A genetic mutation, other factors or potential factors are maternal obesity, having a maternal diabetes, low vitamin B12 levels, and this can be detected prenatally. You'll see an elevated alpha-fetoprotein level in the amniotic fluid. You can see it with a uterine ultrasound. So what this image is actually showing are a variety of midline defects of the spine with varying degrees of neural herniations, okay? So this here is your normal, what you would expect, so it's closed. So spina bifida occulta. So you can see that there's no closure, but it's really not herniating out. Then you have your meningocele and your myelomeningocele, okay? So again, not closed, but then having that herniation, okay, of those tissues. So how do we prevent this? So people or those sex assigned female at birth, when they are childbearing age, making sure they are taking supplementation of folic acid, at least 0.4 milligrams per day. If there's a history of having children with neural tube defects, but are taking 4 milligrams per day. And other ways to get that folic acid beyond taking a supplementation are cereals or grains have been fortified with folic acid. And again, supplementation, if they are going to take supplementation, really should begin prior to conception. And this is found to potentially prevent like 50 to 70% of all cases of these neural tube defects. So long-term treatment will be required. Need to consider what are most concerning aspects for the child and family. So we really need to advocate for the child, help support the family. We want to make sure that we're preventing trauma to that membranous cyst. We want to, again, assess neural involvement. What activities can they do? Do they have movement? Do they have sensation? For these small infants, need to make sure that they're in a warmer to help manage and control their temperature. We want to prevent drying of the sac, do dressing changes to it, clean it, and prevent any complications, any infections, any bleeds that can occur. And like I mentioned, supporting that family, providing education, because long-term treatment will be required for these patients. And we need to help empower our families to be advocates for their child. Infants and children with myelomeningocele or spina bifida, depending on the location, you may see them have neurogenic bladder dysfunction. So they do have to clean intermittent cath in order to empty their bladder. They often will have bowel regimens to help maintain some control of the bowels. And they may have mobility issues or motor and sensory deficits, depending on where that lesion is occurring or has occurred. Other things that I really didn't mention either when I've initially talking about that acute care management. Post-surgically, again, assessing vital signs, monitoring intake and output, providing nourishment, observing for those signs of infection, managing their pain, looking for signs of cerebral spinal fluid leakage. And patients that have myelomeningocele or spina bifida are prone to develop latex sensitivities. So we need to reduce exposure from birth onward, which really can decrease that chance of allergy development. And they can develop this allergy because of the repeated exposure. So you're going to see majority of children with spina bifida or history of myelomeningocele, they will have latex listed as an allergy. So we really want to pay attention to that and make sure that we're using things that are latex free. So that ends this portion of the presentation. Have a wonderful day.